Hello everyone. Welcome to the channel. Invasive fungal infections are among the deadliest infections encountered in critical care. Mortality often exceeds 40 to 60%, especially in patients with septic shock, prolonged ICU stay, neutropenia, organ transplantation, ECMO, or prolonged corticosteroid therapy. The biggest challenge is that traditional fungal culture is slow and insensitive. Blood cultures detect only about 50% of invasive candidiasis and often take several days to become positive. Today's ICU therefore increasingly relies on rapid biomarkers and molecular diagnostics that allow earlier diagnosis and earlier initiation of appropriate antifungal therapy. In this video, we will discuss the latest diagnostic tests available for invasive fungal infections and understand where each fits into modern ICU practice. Let's first understand the limitations. Blood culture remains the gold standard for species identification. However, sensitivity is low. Results take 2 to 5 days. Many patients have already received antifungal therapy. Aspergillus almost never grows from blood cultures. Mucormycosis is notoriously difficult to culture. By the time cultures become positive, the opportunity for early treatment may already have been lost. This is why newer diagnostic techniques have become increasingly important. Let's begin with the most widely used fungal biomarker. Beta-D-Glucan is a polysaccharide present in the cell wall of many fungi. It is elevated in infections caused by Candida, Aspergillus, Pneumocystis jirovecii, Fusarium, and Trichosporin. However, remember an important limitation. Beta-D-Glucan is usually negative in mucormycosis and cryptococcus. Because their cell walls contain little or no beta-D-glucan, Thevanages detects infection before cultures become positive. Excellent negative predictive value. Useful for screening high-risk ICU patients. False positives. Several ICU situations can falsely elevate BDG. Hemodialysis with cellulose membranes, albumin infusion, intravenous immunoglobulin, major surgery, severe bacterial infections, gauze exposure, and certain antibiotics. Therefore, BDG should never be interpreted in isolation. Always combine it with clinical assessment and imaging. Galactomannan is a polysaccharide released by Aspergillus during growth. It can be measured in serum and bronchoalveolar lavage fluid. Ball galactomannan is considerably more sensitive than serum testing. It is particularly useful in neutropenic patients, hematologic malignancies, lung transplant recipients, and ICU patients with suspected invasive pulmonary aspergillosis. False positives may occur with certain antibiotics, cross-reactive fungi, and some enteral nutrition products. Galactomannan has become an important component of diagnosing invasive pulmonary aspergillosis. Another useful biomarker combines Mannan antigen and anti-Mannan antibody. Neither test alone is sufficiently sensitive. However, combining both significantly improves diagnostic accuracy for invasive candidiasis. Their use varies between institutions but may be particularly valuable in selected high-risk patients. Polymerase chain reaction has transformed fungal diagnostics. PCR detects fungal DNA directly from blood, bronchoalveolar lavage fluid, tissue, and sterile body fluids. Advantages include results within hours, higher sensitivity than blood cultures, species identification, and early diagnosis before cultures become positive. Some assays can also identify antifungal resistance mutations. Examples include azole resistance mutations in Aspergillus fumigatus. PCR is now incorporated into many European diagnostic algorithms. One of the most exciting innovations is the T2 Candida system. Unlike conventional culture, T2 Candida detects Candida directly from whole blood using T2 magnetic resonance technology. No blood culture is required. Results are available within 3 to 5 hours. The test identifies the 5 major Candida groups responsible for over 90% of candidemia: Candida albicans, Candida tropicalis, Candida parapsilosis, Candida glabrata, and Candida krusei. Advantages: extremely rapid, high specificity, detects candidemia even before cultures become positive, may remain positive despite prior antifungal therapy. Limitations: detects only Candida, cost is relatively high and limited availability. Matrix-assisted laser desorption ionization, time of flight mass spectrometry. This technology has revolutionized microbiology laboratories. Once an organism grows in culture, MALDI-TOF identifies fungal species within minutes by analyzing protein fingerprints. Advantages: rapid species identification, highly accurate, cost-effective after installation, and helps early optimization of antifungal therapy. However, it still depends on culture growth. It is not a direct detection method. Perhaps the most advanced technology today is metagenomic next-generation sequencing. This method sequences all microbial DNA present in a clinical sample. It can simultaneously detect Candida, Aspergillus, mucor, rare molds, mixed infections, and unexpected fungal pathogens. It is particularly valuable when conventional cultures remain negative. The patient is deteriorating despite broad-spectrum antimicrobials. Rare fungal infections are suspected, and tissue samples are difficult to obtain. Limitations include high cost, limited availability, complex interpretation, and detection of colonization rather than infection. Nevertheless, NGS represents the future of infectious disease diagnosis. A newer point-of-care test is the Aspergillus lateral flow device. It works similarly to a rapid antigen test. Advantages include results in less than 1 hour, can be performed on bile fluid, useful in resource-limited settings, and rapid bedside decision-making. Although promising, it is usually used alongside Galactomannan and PCR test rather than replacing them. Rather than relying on a single investigation, modern fungal diagnosis follows a multimodal approach. For suspected candidemia, blood cultures, Beta-D-Glucan, T2 Candida, where available, and PCR. For suspected invasive pulmonary aspergillosis, high-resolution CT chest, bronchoscopy with Galactomannan, Aspergillus PCR, and fungal culture. For suspected mucormycosis. Remember, neither Beta-D-Glucan nor Galactomannan is reliable. Diagnosis depends on tissue biopsy, histopathology, PCR, and molecular sequencing. Artificial intelligence combined with molecular diagnostics is likely to become the next frontier. Future ICU laboratories may soon provide pathogen identification, resistance genes, virulence markers, quantitative fungal load, and personalized antifungal recommendations, all within a few hours. Before we conclude, remember these important points. Blood culture alone misses many invasive fungal infections. Beta-D-Glucan is an excellent screening test but has false positives. Galactomannan is most useful for invasive aspergillosis. PCR enables rapid fungal DNA detection before cultures become positive. T2 Candida provides rapid diagnosis of candidemia directly from blood. MALDI-TOF rapidly identifies fungal species once culture is positive. Metagenomic next-generation sequencing is transforming fungal diagnostics, particularly for rare and culture-negative infections. And lastly, no single test is perfect. Always integrate clinical suspicion, imaging, microbiology, and biomarkers. Early diagnosis saves lives in invasive fungal infections. Modern ICU practice is moving away from waiting several days for culture results and toward rapid molecular diagnostics combined with fungal biomarkers. Understanding the strengths and limitations of each test allows clinicians to initiate timely, targeted antifungal therapy and improve patient outcomes. If you found this video helpful, please like, share, and subscribe to the channel. Don't forget to turn on notifications so you never miss our upcoming evidence-based critical care videos. Thank you for watching, and I'll see you in the next video.